It's 8 o'clock. We can start our classroom. Over to President Nemboy, Professor B.S. Kumar Das.
Good evening, everybody. At the very outset, I would like to welcome our chief guest expert, Professor Neeraj N. Mathur, and our speaker from Guwahati Medical College, Dr. Shivangi Sahu, and moderators, Dr. M.N. Borua and Dr. Kumkum Bora. So it is our routine program we are doing, and we need some expert opinion. And I request Dr. N.N. Mathur to give a good opinion about this, because we have started for the benefit of our juniors as well as our seniors. So we'll be starting like this. Welcome. Thank you. Thank you very much.
Now over to Secretary Dr. Anjan Jyoti Bhaya to introduce our chief guest of this occasion.
It is an honor to introduce Dr. N.N. Mathur sir, a distinguished ENT surgeon and academician, and currently serving as a professor and head of ENT at Amrita Institute of Medical Science, Faridabad. Dr. Mathur holds MBBS and MS from Maulana Abdul Azad Medical College, New Delhi, and has over 40 years of experience in the field of otolaryngology. He has previously led two of the most prestigious medical institutions in the country, EMMC and Safdarjung Hospital, and Lady Hardinge Medical College, New Delhi, as principal and the director for 6 years. He has also served as additional DGHS and Professor of Excellence at LHMC. Dr. Mathur has contributed significantly to the medical education and curriculum development, being actively involved in teachers' training and the development of competency-based MBBS curriculum under Ministry of Health and Family Welfare. He has been an undergraduate and PG examiner for the last 35 years and served as an expert for national bodies, universities, and public service commission. His area of expertise include pediatric otolaryngology, pediatric airway surgery, head and neck cancer surgery, skull base surgery, otology, and cochlear implant. He has been awarded several prestigious fellowships like Graham Fraser Fellowship in Cochlear Implants, Commonwealth Fellowship in Pediatrics ENT, WHO Fellowship, ICMR Fellowship in Pediatric ENT, Fellow of National Academy of Medical Science, and a Fellow of Royal Society of Medicine. Dr. Mathur has led multiple research projects, published more than 90 research papers, and participated in over 500 national and international conferences, sharing numerous scientific sessions. With his vast experience and contribution in the field of ENT, Dr. Mathur is truly an inspiration to the medical fraternity. So I welcome you, sir, in our Nemboy classroom program.
Thank you, sir. Thank you.
I would like to introduce our first moderator, Dr. Munindra Narayan Borua. He is the founder, managing director at Northeast Cancer Hospital and Research Institute, Jorabad, Guwahati, Assam. Also serves the institute as a chief consultant in the Department of Head and Neck Oncology. He is the head of research division of the institute, which is involved in various research activities in association with different research institutions and universities. Presently also engaged as PhD guide in Tezpur University, instrumental in establishing a tissue bank in IIT Guwahati, trained in head and neck Cancer Surgery at Addenbrooke Hospital, UK, Netherlands Cancer Institute, Amsterdam, and Utrecht University, Netherlands. Honored with the Protein Times Achievers Award 2016 for contribution in the field of healthcare services in Assam, has presented papers in conferences held both internationally and nationally, has published papers at the national and international journals like Immunogenetics, Frontier in Oncology, Biomolecules, Human Gene, Human Immunology, Global Journal for Research Analyst, etc. Has been founder member of Foundation of Head and Neck Oncology in India, a member of European Society of Medical Oncology, member of American Head and Neck Oncology, advisor at Predomix Technology Delhi in the field of metabolomics for early diagnostic of cancer, has been socially active towards bringing up awareness campaign on cancer and anti-tobacco in the region. We have also amongst us Dr. Kumkum Bora as one of the other moderator. He started his career in Guwahati Medical College as assistant professor, then served at different capacities in Jorhat Medical College, Assam Medical College, and now he is professor and head of the Department of ENT and Head and Neck Surgery, Pragjyotispur Medical College. He has numerous publications in national and international journal. His area of interest is face, micro-ear surgery, and cochlear implant. I would like to introduce our speaker, Dr. Shivangi Sahu. Shivangi Sahu, she has done MBBS from Jorhat Medical College in the year 2019 and pursued postgraduate from Guwahati Medical College. She is in the year 2022. Regarding her achievement, she has received second prize in poster presentation in NABOICON 2024 held in Sibsagar. Her work was on disease-specific quality of life in children with various ear diseases, a tertiary hospital-based prospective study. So now over to Shivangi for your presentation.
Thank you, ma'am. Thank you, ma'am. Good evening to everyone present here. Respected senior consultants, respected professors, seniors, my colleagues, and my juniors, I'd like to welcome everyone to today's NABOI classroom on the topic surgical anatomy of deep neck spaces. I'd like to begin the presentation with a quotation by Jean Fernald, who says, "Anatomy is to physiology as geography is to history, and it describes the theater of events." I'd also like to forward my thanks to Dr. Kumkum Bora sir and Dr. Aman Bora sir for moderating me throughout the preparation of the presentation. Now, today we have chosen this topic on board because the intricacy and the complexity of the anatomy of the neck is very important, because in this area we come across lots of diseases ranging from infections to abscesses to tumors, maybe malignant or maybe benign. So while addressing these diseases as an ENT surgeon, every second step or every fourth step leads us to an important structure. Hence, a vivid knowledge or a comprehensive idea about the compartments, its contents is very important, so that we don't land ourselves in complications which gives surgeons sleepless nights. I'd like to move forward with the presentation, starting with the surface anatomy of the neck. The superior border is the mandible with the deep limits of the floor of the mouth anteriorly and the skull base posteriorly, while the inferior limit is the upper respect of the first rib and the first thoracic vertebra. vertebra. Coming to developmental anatomy, the structures in the neck that are innervated by the cranial nerves are derived from the branchial apparatus. Each arch has its own cranial nerve, cartilage, and artery. The first arch obliterates soon after all the branchial arches become apparent. Between the arches sits the internal pouches and external clefts or grooves. So as we have described, this picture shows the pharyngeal apparatus. The balloon-like structures are the arches coming from the mesoderm. The internal invaginations are the pouches from the endoderm, and the external invaginations are the clefts from the ectoderm. Here we can see that the fifth arch has regressed. Now, this table vividly describes all the arches and its contents. Now, the first arch gives the nerve, trigeminal nerve, the mandibular division, and the Meckel's cartilage, the maxilla malleus incus, the muscles like mylohyoid, anterior digastric, tensor tympani, tensor velipalatini, and muscles of mastication. But the artery gives the first aortic arch, it is a maxillary artery, and the internal pouch gives eustachian tube, middle ear cleft, median surface of the tympanic membrane, while the external auditory meatus and the lateral surface of the tympanic membrane is given by the external cleft. Coming to second arch, it is a hyoid arch. It gives a facial nerve, the richest cartilage, the lesser cornu and the upper border of the hyoid, stapes, suprastructure, and styloid process. The muscles of the facial expression, posterior belly of the digastric, platysma, and the stapedius. The second aortic arch and the sepidal artery are its arterial contents. The internal pouch gives the palatine tonsil, while the external cleft gives the grooves of the remaining grooves. The third arch gives the glossopharyngeal nerve, the greater cornua and the lower body of the hyoid, the stylopharyngeus, the superior and the middle constrictors, and the third aortic arch. The internal pouch gives the inferior parathyroid gland and the thymic duct, while the external cleft is obliterated. Coming to the fourth arch, it gives the superior laryngeal nerve of the vagus nerve, the thyroid lamina, the cricothyroid, the fourth aortic arch or the arch of aorta, the superior parathyroid gland with the internal pouch, while the external cleft is obliterated again. Coming the sixth, that is the recurrent laryngeal nerve of the vagus nerve. It gives the cricoid and the arytenoid cartilage, the inferior constrictor, and the intrinsic muscles. The sixth aortic arch, the ductus arteriosus, and the ultimobranchial body by the internal pouch, while again the external cleft is obliterated. Now we have described each of these arches very vividly because of the congenital abnormalities associated with them. Now we can see that the branchial clefts has different kind of congenital abnormalities. The first is the are of two types, that is the work type 1 and the work type 2, whose external openings are the anterior and the inferior to triggers, while the internal is the external ear or the middle ear, and it lies very close to the facial nerve. Coming to the work type 2, it's posterior to the angle of the mandible, and internal opening is conchal ball or the external ear canal. It is very inconsistent with the facial nerve. Coming to second, which is the most common type of the cleft fistula, its anterior external opening is in the anterior border of the sternocleidomastoid muscle, while the internal opening is in the tonsillar fossa. The third and the fourth is a very rare kind of fistula. Its external opening is in the anterior border of the sternocleidomastoid muscle, and the internal opening is the piriform fossa. Third is superior, and fourth is inferior, the superior laryngeal nerve. Now, each of these fistula tracts has very similar kind of presentation, either skin or ear discharge, and ranges to respiratory tract infection to recurrent thyroiditis. And management is very much similar. We will go for the surgical excision of the fistula tract. Coming to the fascial layer of the neck, in this picture, we can see it has two main divisions, the superficial layer that is in the subcutaneous tissue and the deep layer, which again has its own compartments. Coming to the superficial cervical fascia, this thin layer of fascia invests the platysma muscle and is penetrated by small vessels supplying the skin. Inferiorly, this creates an aponeurosis that either attaches to the skin of the neck or continues inferiorly, becoming continuous with the fascia of the deltoid and the pectoralis major muscles. Now, the surgical importance is that whenever we do a procedure or in like the thyroid surgery or a neck dissection, we always lift the flap in the subplatysmal plane in order to preserve the blood supply of the skin. Second is necrotizing fasciitis. We often get these patients in our wards. The causative organism is always Streptococcus and Staphylococcus. Hence, also it's called the streptococcal gangrene. It's mostly associated with diabetes mellitus and other immunodeficiencies, and sometimes with history of trauma. Clinical feature ranges from erythema, swelling, disproportionate tenderness, thrombosis of the skin vessels, hypoesthesia, and frank gangrene. It can be diagnosed clinically, but CT always helps us to identify any gas in a soft tissue. Management includes high-dose antibiotic coverage, fluid and electrolyte correction, and aggressive debridement. And we can go for plastic surgery like skin grafting if required. Coming to deep cervical fascia, it has 4 layers, the investing layer, the carotid sheath, the pretracheal fascia, and the prevertebral fascia. The investing layer. As we can see in this diagram, the investing layer has the superficial layer of the deep cervical fascia. It origins from the ligamentum nuchae and the spinous process of the cervical vertebrae posteriorly. It encloses the sternocleidomastoid muscle and the trapezius muscle, the infrahyoid and the masseter muscle. It splits to enclose a parotid gland called the parotid fascia and the submandibular gland. Carotid sheath, we can see here in this diagram, it is medial to the sternocleidomastoid muscle and encloses the common carotid artery and the internal and external carotid arteries after bifurcation, the IJV and the vagus nerve. The pretracheal sheath, this is a middle layer of the deep cervical fascia known as a visceral layer. It attaches to the hyoid bone superiorly and can be considered as having 2 parts. First is the muscular compartment, which encases the infrahyoid muscle, and second we have the visceral compartment containing the trachea, the thyroid, the pharynx, and the upper esophagus. In this diagram, we can see this is the pretracheal fascia. These are the infrahyoid muscles. We have the thyroid gland, the esophagus, and the pharynx. Now, laterally, it connects to the carotid sheath by Roux areolar tissue. Then the prevertebral fascia. It encompasses the posterior neck muscles, the scalene muscles, and the vertebrae. It forms the floor of the posterior triangle and represents the deep limit of the neck dissection and the plane between the cervical vertebrae and the upper aerodigestive tract. Now, in this slide, we will discuss about the different fascias and the spaces between them. This is a sagittal picture and this is a transverse picture. Here we can see this is the vertebral body. This is the vertebral body. In front of the vertebral body, we have the vertebral space in white color. In front of the vertebral space, we have the prevertebral layer. And in front of the prevertebral layer in red, we have the the danger space, which lies between the prevertebral fascia and the alar fascia. In between the red space and the yellow space, we can see a black line. This is the alar fascia, and in front of it is the retropharyngeal fascia, which extends from the skull base to the second thoracic vertebrae. And in front of the retropharyngeal fascia, we have the middle layer of the deep cervical fascia. Coming to the neck spaces, between the facial layers of the neck are several anatomical compartments. Whilst the facial layer limits the spread of infection, these interconnected spaces can act as a route of transmission of infection or neoplasia. As we can see in this diagram, it's a schematic diagram of all the spaces. So hence, all of the spaces are very much near to each other, and disease in one's area can always lead to disease in the other area. Coming to the submental space, the border of the submental space corresponds to the submental triangle with the superficial limit of the superficial cervical fascia and the deep limit of the mylohyoid muscle and the geniohyoid muscle. The lymph node of level 1A are found within this space. Surgical importance is the submental space infection. It's mainly odontogenic. Causes erythema, induration in the submental skin along with pain, odynophagia, minimal airway compromise, and moderate dysphagia. Management mainly involves IV antibiotics, incision drainage, and mainly treatment of the odontogenic cause. Now, in the spaces of the neck, especially if we talk about the infections, the management will be very much like antibiotic coverage or incision drainage, and then treatment of the cause of the disease. But what is important in anatomy of the neck and its spaces is the knowledge about its extensions, the contents, and the complication that it can lead to. So our main focus is that to know about the contents and the extent of the spaces. the submandibular space, the key clinical significance is that it is the route of spread of infection between the neck and the floor of the mouth. Superiorly, the mucosa of the floor of the mouth. Inferiorly, the investing layer of the deep cervical fascia from the mandible and the hide bone. Anterior and posterior borders are formed by the anterior and posterior bellies of the digastric muscle. The superficial limit is the investing layer of the deep cervical fascia, which wraps around the submandibular gland. Here we can see the submandibular fascia. This is a sublingual gland along its contents, the submandibular duct and the lingual nerve and the veins. And this is a submandibular gland. The mylohyoid muscle runs through the middle of the submandibular space, dividing it into the superior and the inferior quadrant. The superior space or the sublingual space contains the sublingual gland, the deep portion of the submandibular gland, and the lingual nerve. While this inferior space holds the superficial lobe of the submandibular gland, both areas contain lymph nodes and branches of the facial vessels. Now, in this picture, we can see that the floor of the mouth is involved, and this is what differentiates between the submandibular gland infection, that is the Ludwig's angina, and the submental infection. Coming to its surgical importance, very much important to discuss about the Ludwig's angina because it is a very fast-growing cellulitis infection that affects the floor of the mouth. The most common cause of Ludwig angina is the abscess lower molar tooth injury inside the oral cavity, oral surgery complication, or pericoronitis tooth. Bacterial species that commonly cause Ludwig angina are Streptococcus, Staphylococcus, and Bacteroides. Clinical features are difficulty breathing, difficulty swallowing, drooling, fevers or chills, jaw pain, neck pain, protruding or swollen tongue, slurred speech, tongue tenderness or pain under the tongue, and toothache. The treatment is IV antibiotics, surgical drainage, and tracheostomy if needed, and treatment of the cause. Now, in this diagram, we can see that the incision is made. This is a typical Ludwig's angina incision, which extends from one digastric to the other digastric in the submandibular region. Peritonsillar space. The potential space between the palatine tonsils and a superior constrictor muscle is known as the peritonsillar space. Surgical importance has the acute and the chronic tonsillitis, which can be managed conservatively, or either we can go for tonsillectomy. And peritonsillitis and peritonsillar space abscess, which is again a complication of recurrent acute tonsillitis. Here, our treatment of action is antibiotic coverage and abscess drainage. So the stab incision that we do is in the intersecting point of the two lines. First line is along the anterior pillar, and second line is along the base of the uvula. Here we give the stab incision, we drain the pus and send for culture sensitivity. Again, we can start the empirical antibiotics. Now, one more important thing about the peritonsillar space or the procedure involved here, that is tonsillectomy, is that the very important space is just lateral to the space, that is the parapharyngeal space, and it contains very many important structures will we discuss later on. Coming to retropharyngeal space, between the two parapharyngeal space is a retropharyngeal space which is continuous with the both. Superior limit is a skull base, inferior limit is a posterior mediastinum down to the level of the carina. Anterior limit is a buccopharyngeal fascia which encases the pharyngeal constrictors, and posterior limit is the alar fascia component of the prevertebral fascia. Contents are the retropharyngeal lymph nodes. Coming to surgical importance, lymph nodes typically regress by adulthood, but can represent a route of metastatic nodal spread from midline or posterior tumors of the pharynx. And second is the acute and the chronic retropharyngeal abscess. In this diagram, we can see the retropharyngeal abscess, the prevertebral thickening, and also the air shadows. So in retropharyngeal abscess, in case of acute retropharyngeal abscess, our main idea will be to drain the abscess. We ask the patient to lie supine, put the head in the hanging position, and we put a stab in the most prominent bulge of the posterior pharyngeal wall. Now, this picture shows the bulge in the posterior pharyngeal wall. For the chronic retropharyngeal abscesses, it's mostly after tuberculosis. Hence, we go for the anti-tubercular treatment. The prevertebral space. The prevertebral space is a potential area posterior to the prevertebral fascia and anterior to the vertebral column and the paraspinal musculature. Clinical importance is spread of infection of this area may occur as a result of traumatic perforation of the pharynx or the esophagus, or because of breach of prevertebral fascia from the retropharyngeal infection. Carotid space. The carotid space is a potential space within the carotid sheet, which is itself formed from a condensation of all the layers of the deep cervical fascia. It contains contains common carotid artery, the IJV, the vagus nerve. Clinical importance is the most common space-causing carotid sheath involvement is a lateral pharyngeal wall infection, and it can spread to the mediastinum through this pathway. Coming to the parotid space, the parotid space is formed by the investing layer of the deep cervical fascia that splits to encompass the parotid gland, the facial nerve, the retromandibular vein, and the terminal branches of the external carotid artery. Clinical importance are the parotitis and the parotid abscess. Now, in both these pictures, we can see the cheek swelling in the patients. What we can do for these patients is we can treat them conservatively, or we can drain the abscess. One more important implication of parotid abscess is the tumors like the parotid tumors. The treatment of which includes excision, and the importance there lies as the facial nerve. So it's very important that we identify the course of the facial nerve, so hence we can preserve it. The visceral space. The visceral space is bounded by the middle layer of the deep cervical fascia that envelops the thyroid and the trachea anteriorly and posterior by the pretracheal fascia. It extends from the skull base above through pharyngomaxillary space along prevertebral fascia below hyoid into the chest below cavitate. It is formed by all three layers but anatomically separate from all the layers, and is called the Lincoln's highway. It contains the larynx, the hypopharynx, the cervical esophagus, the proximal trachea, thyroid, parathyroid glands, and the lymphatics of the level 6. Coming to the last space, that is the parapharyngeal space, also known as the pharyngomaxillary space or the lateral pharyngeal space. It lies lateral to the pharynx with extension from the skull base to the hyoid. Now, it is like a inverted pyramid, the base as the roof and the apex as the floor. Anteriorly, we have the interpterygoid fascia and the pterygomandibular raphe. Posteriorly, we have the prevertebral division of the deep layer and the posterior aspect of the carotid sheath. Medially, we have the middle layer of the cervical fascia around the pharyngeal constrictor and the fascia of the tensor liver palatine muscle. Laterally, we have the superficial layer of the deep cervical fascia that overlies the mandible and the medial pterygoid and parotid. It has two compartments, the pre-style of the anterior, which consists of the loose areolar tissue, lymph nodes, and the internal maxillary artery, and the post-styloid or the posterior region, which includes the most important structures, that is the carotid artery, the IJV, the cervical sympathetic plexus, or the cervical cranial nerves, that is the 9th, 11, 12.
মেজর না মোটামুটি আছে এগুলো ডান দিকে যে
Surgical importance is any pathology in the space can be primarily disease of its contents or secondary to autoimmune disease like tonsillitis, silenitis, or lymph nodes. Thank you.
Thank you, Dr. Shivangi, for your presentation. Now, I'd like to request our chief guest of this event, Dr. Mathur sir, to speak on this subject, and also few suggestions regarding our Nevoy classroom, how we can improve our this classroom. Can you stop sharing your slides so that I can spotlight, sir?
Yes, ma'am.
Thank you very much, ma'am. And it was very nice listening to the young postgraduate student, and she has covered the topic very well. I think what needs to be emphasized is that there is the space. Space usually means that we get an idea that it is a space which is occupied by some air, or that there will be some space when we operate. There will be some air sort of a thing there. So one need to know that these are all potential spaces, and they are filled up with they can enlarge because they have the loose areolar tissue, but they are not spaces as such when we dissect or when we operate. But yes, when an abscess forms there, or when the tumor goes there, then it enlarges and these spaces become relevant. So these spaces otherwise are just collapsed things, and they are not really the spaces in real sense in normal circumstances. In disease circumstances, they become spaces and they become filled up with things, and they become relevant. And there was another thing that was told that when we raise the flaps, we raise it in the subplatysmal plane. That is very true. And so how does the surgeon decide that this is a subplatysmal plane? Because once you cut the platysma, you are below it. And then once you are below it, then you can be a little deeper also. So how will you decide that you are exactly in the subplatysmal plane? So you have to sort of see that the platysmal sheath, you look underneath it. So the surgeon should be looking below it and then dissecting out just below the platysma to be exactly in the subplatysmal plane. Otherwise, the fault will be made and you will go a little deeper. And many a times, the raising of the flap is not in the subplatysmal plane, but in a deeper plane. So if you really want to be in a subplatysmal plane, then it is to be just exactly in the subplatysmal plane, just below the platysma. And the best way to do is to inculcate the habit of looking from sort of once you have just raised it from below, try to look from underneath it and remain as close as possible from below to the platysma. All these spaces are very important, and the abscesses there are very important, especially for the residents day in and day out. They will be in the emergencies, they will be getting the abscesses in the parotid space or the quincies or the parapharyngeal space. And one more thing that you have to see is that understand is that parapharyngeal space is very important, and it is not the parapharyngeal space occupation which is very important. More important in the radiology is how is the parapharyngeal space displaced. So if there is a mass in the parotid, and it will displace the parapharyngeal space medially and maybe a little anteriorly. If there is a mass in the carotid space, then it will displace the parapharyngeal space little anteriorly. So this parapharyngeal space, which in the MRI in the T1 weighted image looks bright, is to be seen not only for anything occupying the parapharyngeal space, but also it normally being there, but how it is displaced. So displacement of parapharyngeal space is also gives a lot of clues as to it may not be involved as such. Parotid space may be involved. It may be a deep lobe parotid tumor, but what happens is that the parapharyngeal space is getting displaced, and so the radiologist will say that this parapharyngeal shadow is displaced anteriorly, and so he thinks that this is a deep lobe parotid tumor. So knowledge of these spaces, also the knowledge of these spaces in terms of the CT scans and the MRI are very important. CT scans are sort of easier to read because they are more anatomically, we are more oriented towards reading the CT scans. And when it comes to the intricacies of MRI, especially, there are so many things that you can play in MRI that enhancing one structure over another, that one gets confused as to what is what structure. So reading of MRIs in all these tumors and the abscesses and the spaces is very crucial. But very well covered by the speaker, and congratulations.
Thank you, sir. Now over to Dr. Munin Borua, sir. Your comment on this topic. Sir, unmute yourself first.
Okay. Can you hear me now?
Yes, sir. Now you are audible.
Yeah, this is a very nice presentation, no doubt. But thing is that these spaces and facades are really important for limiting the infections as well as the spread of the tumor. Dr. Mathur rightly said that when we do a neck dissection or any surgery on the neck, we always try to find out the platysma first. And we cut the fibers very nicely. Then with the retractor, mainly the skin hook, we retract the flap, upper flap, and we do a subplatysmal dissections, which is totally avascular. There is no bleeding. If your cautery point is under the platysma, there will not be any bleeding. Number two is, if this facial layer actually, they forms a natural avascular plane, which can be utilized for the avascular dissection in the neck. God has given us a fantastic embryology in the neck. If we walk on the facial plane, there will not be any bleeding. I will give an example. In neck dissection, when we retract the anterior border of the sternocleidomastoid from mastoid to the clavicle, if your cautery point is strictly on the anterior border of the sternocleidomastoid, except few muscular branches, which can be cauterized by your diathermy, this bipolar diathermy, you can, from the anterior border of the sternocleidomastoid, you can enter the P vertebral space without a bleeding. That is very important. When we do dissection, especially the conservative neck dissection, we retract the sternocleidomastoid laterally, strictly on the anterior border, and then we reach the carotid sheath, because this carotid sheath again contains all the mainly 80% of the lymph node of the head and neck cancer patient. And this lymph node carotid fossa is so important and it is so tough. I will tell you, the node which may be very sort of clinically doubtful whether we can remove it or not. The God has given carotid sheath in such a tough structures that it is very difficult to invade the carotid sheath by the tumor. Yes, sometimes you will get, but you can very nicely remove the tumor from the carotid sheath. Another important point in this area, on the carotid sheath, there is a ulcer cervicalis. If you follow the ulcer cervicalis, and if you are in the same plane of ulcer cervicalis, you will not injure any vital structure in the neck. That is very important for this carotid sheath. Another point, from omohyoid muscle, if you work on the omohyoid muscle up to the hyoid bone, there is no chance of injuring to anything. Like posterior belly of the digastric and anterior belly of the digastric, if you work on them, you will not injure any vital structure. So to me, these are very important, and no doubt these spaces not only prevent the spread of infections, it also prevent the spread of the tumor. So with this few lines, I want, if anybody asks any questions, we can discuss. And maybe Kumkum can add something.
Over to Dr. Kumkum.
Thank you, ma'am. Can you hear me, ma'am?
Yes,
Yeah, yeah.
yes, you are audible.
Now, actually, why we actually need to know about these spaces is basically we need to know from where to where the infections are spreading or the spread of neoplasia. About the deep neck spaces,
Dr. Kumkum, there is
Yeah.
one more system is going on in your room, I think. If they can,
There's just some
yeah,
background noise.
background noise is there. Some other, somebody is using some device in your
can you hear me
background.
now, ma'am?
Yeah, a lot of echo is coming.
Now? Can you hear
Yes.
me, ma'am?
Yeah, it is better.
Can you hear me, ma'am?
Yeah, it is better. It
Okay.
is better.
So why, basically for the residents, why we actually need to know about these spaces is because spread of infections and neoplasia. The one thing to remember is that the deep fossa, which covers the muscles, infrahyoid group of muscles, is invariably actually attached to those one bony point. So it actually prevents spread of infections. But the fossa that actually surrounds the viscera is along that lines, the spread of infection is more. I think in our clinical practice, we get a lot of cases of Ludwig's angina. Now, that Ludwig's angina for the residents is not something to be taken very lightly, because in initial stage of cellulitis, it is okay. But when there is a abscess formation, it can compromise the the respiration. The patient may have a dyspneic spell and he may have a stridor. So sometimes we need to go for a tracheostomy to to retrieve the airway. And tracheostomy itself is very much difficult because it's so dense, edematous skin. So sometimes we need to perform a cricothyroidotomy in order to save the retrieve the airway, and also to address the main disease, like it basically occurs in young adults with lower molar teeth being infected. So those has to be taken out, and the abscess needs to be drained. So and there's a huge, the floor of the mouth also swells up. And the one important point to notice in Ludwig's for a young budding surgeons is that there is no fluctuation when you you palpate the floor of the mouth. So that is one suspicion for Ludwig's. Another thing is that about retropharyngeal abscesses, lots of cases we get, but acute case is different from a chronic case. Like it basically occurs in children, we all know, below 2 years of age. And that swelling is also on one side because of involvement of Rouvière's node. And in cases of children, you should not take it very lightly. I think the child has to be mummified with sterile drapes and the head down position. We give a vertical incision and needs to be drained out immediately. Even for adults also, we sometimes get foreign bodies in the pharynx, long-standing pharynx, foreign bodies, giving rise to retropharyngeal abscesses. But how we actually know by doing a radiograph, lateral X-ray of the neck, whether this is an acute case or a chronic case. So these things has to be remembered. In chronic cases, basically we see destruction of the bones in cases of Pott's spine, tubercular spine. So it is adjacent, that is the body of the adjacent vertebrae get destroyed because of the blood circulation is such that the upper end supplies the lower end, the upper vertebra, and the lower end supplies the upper end of the lower vertebra. So these things has to be taken care of. And drainage, actually in chronic cases, we do not do intraorally for fear of fistula. We have to drain it externally. That also has to be remembered. Giving anti-tubercular drugs along the anterior border of the sternomastoid. We can give a longitudinal incision, a vertical incision, and we can drain it. So these things has to be remembered, acute cases and chronic cases. And I think this, because of this whole scenario, like how to treat spread of infections, these spaces are very much of importance. And also, as already mentioned by Sir Mathur Sir and Borua Sir, about the limits of doing neck dissections, like the prevertebral fossa is the posterior, the limit of the deeper limit of excising nodes from the posterior triangle. So I think good, very nice presentation by Dr. Sivangi. And we would like to take some questions in our next sessions. There are lots of questions coming up. So, ma'am, can we go with the questions? I think I sum up with this.
Yes, yes, you can take up that. It is visible to you, Dr. Kumkum.
Okay, there are some questions coming up. Yeah. So, Fukan sir has given one question like deep neck spaces or the triangles of the neck more relevant in malignant nodes management. So I'd like the speaker to throw light on it. Sivangi, can you?
Thank you, sir, for the question. Deep neck spaces or the triangle of the neck are more relevant in malignant nodes management. So when we talk about the
Yes, carry on.
when we talk about the malignant nodes, we usually refer to the levels of the lymph nodes rather than the spaces. Spaces come into account when we go for the infections or the rather also extent of the disease. But for the lymph nodes, we go for the level of the neck nodes.
Hello, ma'am.
Yeah, you're audible. There are a few more questions. Is LF Fukan sir, if you want to add anything?
I do not want to add anything. As Dr. Munin Barua, the head and neck surgeon, is there to moderate. Actually, he's not fit for the facial spaces, rather for the neck dissection of the levels of the nodes. Not just, therefore I put the question. Thank you.
One more question from the sir. Is it visible to you, Dr. Kumkum?
Yeah. One question I would like to take up, like the important question: what are the red flags for deep neck infection? Red flags for deep neck infections. Dr. Sivangi?
Yes, sir.
Red flags for deep neck spaces infection.
Red flags for deep neck spaces infections, as we have discussed about the danger space and the retropharyngeal space, which extends from the base of the skull to the mediastinum. Hence, it is a red flag. Also, if we talk about the parapharyngeal space, which has contents like the carotid artery, the cranial nerves ranging from 9, 10, 11, 12, these are the red flags we can consider because infection in these spaces, they can lead to grave complications. Like if we talk about retropharyngeal abscess, the infection can lead to mediastinitis, or if there is burst in the retropharyngeal abscess, it can lead to pneumonia, aspiration pneumonia, etc. As well for the parapharyngeal abscesses or the infections in the parapharyngeal space, we have the IJV. It can cause IJV thrombophlebitis or thrombosis. Hence, these spaces are red flags for deep neck space infections.
Sibangi,
Yes. Yes,
hello. Acha, regarding red flags, you have explained it, the disease that you have told just now. But
Yes,
actually, I want to a little bit highlight regarding this because there are important red flags to be aware of in suspected, particularly suspected patients.
yes.
Okay. Particularly as this patient also quickly decompensate, and they are sometimes need urgent surgical interventions. So if any of these symptoms particularly are there, then you have to see them as red flags, particularly sore throat. Those having sore throat in the absence of any abnormal oropharyngeal examinations, and you find that is a red flag also. then severe neck pain or stiffness, if presented with this, it also gives a red flags. Okay, any signs of airway compromise, such as stridor, dyspnea, drooling, dysphonia, these are very important part of this red flags. I think these are, we presume these are the red flags for particularly deep neck space infection. I think Kumkum will be better. He will
Yeah,
be-
rightly said, Hemantoda, rightly said. And even after giving very nice antibiotics, and even there is a continuation of leukocytosis in the blood, I think that is also a red flag, because that actually indicates involvement of the mediastinum through Lincoln's highway. It can go even lower down. So definitely these are the red flags. So when there is actually drooling of saliva, creepy cough, then there is a compromise of the airway. These are actually red flags.
Yeah, yes, thank
So
you.
I think we can move to some other question.
Yes.
There's a question from Dr. Priyamvada. So severe sore throat, difficulty breathing, new onset dysphagia, organophasia, drooling. I think she has again given the same conditions of red flags. Okay, Anjanda has given one question: how to manage IJV thrombophlebitis. IJV thrombophlebitis. So there will be involvement of the IJV in parapharyngeal space abscesses. So how to manage the thrombophlebitis?
IJV thrombophlebitis is usually seen in infections near the carotid sheath or the parapharyngeal spaces. Its management ranges from symptomatic treatment, or also we can go for the anticoagulant therapy.
So Anjanda, she have said about IV antibiotics and anticoagulants. Anything you want to add, Dana?
Okay, is there any role for surgical intervention in those cases? Because
Surgical intervention, role of surgical intervention.
Can Dr. Mathur sir can throw some light on this, sir?
Thrombolysis we can go for.
Is there any need to do any surgical intervention, or IJV thrombophlebitis, let it go alone?
Sir, please unmute yourself.
Thrombolysis.
Sir, you are muted. Mathur sir, you are muted.
Sorry. Earlier days, probably the surgical interventions were more in cases of internal jugular vein thrombophlebitis. But as we have more advances in the medicine and more antibiotics available and anticoagulants, we hardly are doing interventions in the internal jugular vein thrombophlebitis but yes, there would always be a reason in case the surgeon feels that it is extending down and it is going to create more complications that one may. But I have not seen for a long time surgical intervention in IJV thrombophlebitis.
Right, sir.
Dr. Kudus Amit sir is here in this group. Sir, if you want to, you have added one point in red flag side. Can you share your input on that question?
In deep neck space infections, actually, especially in adults, I think to diabetes mellitus, uncontrolled diabetes mellitus can result in sort of spread of these infections in all directions, especially the danger of going into the chest and the mediastinum. That's why the diabetes must be the first thing to be excluded when you're talking, thinking about these abscesses in adults, especially.
Thank you, sir. Any more questions, Dr. Kumpum?
Yeah, we move on to the next question. Mukherjee sir has given one question, like importance of the stylomandibular ligament in pre-styloid and post-styloid compartment, I think in MRI. That's what he meant. Importance of stylomandibular ligament, pre-styloid and post-styloid compartments in MRI. Stylomandibular ligament. Sivangi, you can try.
The pre-styloid and the post-styloid compartment. The pre-styloid compartment mainly has the fatty tissues, while the post-styloid compartment has the most important structures. The stylomandibular ligament acts as a partition between both these compartments. Hence, we can in MRI the breach of this ligament can be taken as a danger sign or a red flag for the prognosis of the disease.
Mukherjee sir, you want to add something?
I can hear you. Yeah. Now it is okay. The splaying of the ligament will tell at what direction. Just now, our speaker was also telling, as well as moderator were telling, the splaying of the ligament itself will cause the displacement of the parapharyngeal space anteriorly or backwards, depending on which segment. Because pre-styloid and post-styloid, pre-styloid, as you know, not much of tissue is there. Actually, the post-styloid, where the vascular nervosa as well as vasculosa is there. So naturally, important vessel there on the base of the skull. So definitely, when you are dealing with case of, say, schwannoma of the vagus, like that. So when you are trying to lesion out, then probably you have to go into that space and find out what is the extent of the lesion, so that it helps you to know also, helps to operate also. Because ultimately you are going through the submandibular space only. You are going up.
Yes.
So that is the thing. Okay.
Hello, Madam Ji.
Yeah, so you are approaching the parapharyngeal space through the submandibular space. Actually, one more question we can take up. Phukan sir has given, is LR fossa consistent? We all know that talking about the danger space between the LR fossa and the prevertebral fossa. So sir is asking one question, is the LR fossa, the LR layer of the deep cervical layer, cervical fossa, is it consistent? Sivangi.
Just like the danger space and the retropharyngeal fascia space, it extends from the base of the skull to the mediastinum or the coccyx. But the LR fascia is a fascia between the retropharyngeal and danger space, which does not extend so down. I don't understand.
Is it consistent?
It's a consistency like along the course of the extension.
I think in the current scenario with more recent advances in dissection, I think this has been nowadays found out to be a very consistent layer extending from the skull base up to the second thoracic vertebra. Before, while dissecting the retropharyngeal space, this fossa was almost not that traceable, but now with current techniques, I think this is consistent layer. Phukan sir, you want to throw some light on this?
Actually, it is written that the LR fascia is origin from prevertebral fascia.
Yeah.
Actually, therefore, it is not a consistent fascia. If it is not a consistent, then your retropharyngeal space will mingle with the prevertebral space. Then same danger line up to the diaphragm. Where LR space is the danger because its space gone to the diaphragm from the base of the skull. But unlike your retropharyngeal space. But when
Yes, rightly said.
is not
Actually,
there,
this fossa is with the prevertebral fossa.
yeah.
So before it was very difficult to actually,
Yeah,
demarcate both the
delineate.
fossas.
Very thin fossa,
Very thin
difficult to
fossa.
delineate. You cannot know that this is the LR fossa.
Yeah. So
Particularly
it's one of the very thin layer of prevertebral fossa. It's actually just in front of the prevertebral fossa and just posterior to the buccopharyngeal fossa.
Buccopharyngeal fossa, above the bucco.
So, and more questions? Fukans have also asked about MRI, fatty layer pressing helps in expansion of MRI T1. So what do you want actually asking actually in this question? We can find out.
No, it is in the continuation of the Dr. Mukherjee's.
Okay, okay. The stylomandibular ligament.
He's in
Okay.
Vietnam now.
Yeah. The pre-styloid has got more fat.
MRI has got actually, when we describe the anatomical feature of facial spaces side by side, if you give some MRI or the CT, as Dr. Mathur has told, give a photograph, then more relevant because the CT or MRI of the neck spaces, unlike dissection, you can in MRI you can detect in T1 image. She has mentioned about that. The fat is in the pre-styloid, the fat will be compressed so nicely that it shows, you can show with expansion of the tumor of this, they can be seen. And yes, already Mukherjee has explained other things. And Shivangi also explained that one. Thank you, Shivangi.
Yeah, there is one more importance actually. One stylomandibular canal is there, like that if the tumor spreads through that canal, it basically appears as a dumbbell-shaped tumor.
Yeah.
Parapharyngeal space tumors. And clinically, definitely it will just it will push the tonsils medially and anteriorly, but there will be no congestion of the tonsils. That's one important clinical finding.
Yes.
Any more questions?
Can I just put a word on this topic
Yes,
about the parapharyngeal lesions? Dr. Mathur has already mentioned about the CT scan versus the MRI. CT scans we are more tuned to, reading CT scans, and the CT scan, if we use it judiciously, you can make out the position of that parapharyngeal fat space, which
yes, sir.
Yeah, because the position of the fat space, when you compare both sides, the fat shadow will move. Say, if it is in say the deep lobe of the parotid, this fat shadow will move posteriorly and medially.
Yes.
So if it's in the retrostyloid compartment, it will move anteriorly.
Spelling of the air shadow.
That is the fat shadow actually. So that will move anteriorly in the if the lesion is in the retrostyloid compartment.
Yes.
So this is one of the things, because CT scans we are more tuned to reading more than MRI. MRI, I still get confused reading all these T1 and T2 images. Unless you have that chart in front of you, you always get confused with the MRI reading.
Yeah, so sir has said that CT will be more helpful in determining the fat spaces, which is related to the parapharyngeal space.
Yes.
Kumkum.
Yes, sir.
Actually, yes, CT scan is also important, but things that anything above hyoid, okay?
Yes, sir.
MRI is best, and below hyoid, CT scan is best.
Okay. So that's another very important point shared by Borwa sir. So just above I think the greater contour of the hyoid, MRI is superior. And that is also the lower limit of your parapharyngeal space, which extends from the skull base to the greater corner of the hyoid. So above the hyoid, MRI gives a better picture, and below CT scan gives a better picture.
Yeah, if you can read the MRI well, that gives a better picture in parapharyngeal actually.
Kumkum, can I add one thing?
Yes, sir.
Just it may be different also. When we do laryngectomy, okay? When we
Yes.
do laryngectomy, we generally dissect wide field laryngectomy from vein to vein, okay?
Yes, sir.
So when we break the carotid space or carotid sheath, then both the carotid sheath we break, then we can put a finger below the P vertebral fossa, and we can put the finger to mediastinum to the base of the skull, and then you can dissect within a second this area very nicely without any problem. It is a totally avascular plane. So you need not do more meticulous dissection. Just put the finger from one carotid sheath to another carotid sheath and leave the finger.
Okay.
Sir, have you ever seen any skull-based osteomyelitis spreading through this plate? Yes.
Myself, I have not seen. I have not seen any osteomyelitis in base of the skull. Maybe some diabetic patient may come. I don't know exactly. We are not doing that. We are not encountering with this patient. Have you have any experience with this one?
No, sir. That's why I have asked you.
No.
With the skull-based osteomyelitis cannot spread through this place, or is there any restriction or something like that?
Maybe patient must be diabetic or immunocompromised for this osteomyelitis.
Yes. But the skull-based osteomyelitis cases that not yet seen that has spread to this prevertebral space or like this.
Maybe, yeah.
Skull-based osteomyelitis
skull-
is basically what we see in malignant otitis externa is basically limited to the skull-based the upper limit of the parapharyngeal space. Okay. I think some petrous apex tumors can also come down into the parapharyngeal.
Petrositis, yeah.
Yeah. Petrositis things can come down. Any more questions?
Kumkum, you want to conclude?
Any more questions? I think there is no more questions. So I would like to conclude with this. Thank you, our speaker, and thank you, everyone. Thank you, our guest speaker,
Now, for official vote of thanks, I would like to request our Joint Secretary, Dr. Hemanta Mohan. Over to Dr. Hemanta.
Yeah, thank you, Anjana. Today's presentation was one of the very nice presentation, and it is a very lucid, and interaction was very good. Shivangi explained very nicely regarding the anatomical part. Of course, surgical part is always difficult for PG student. Experienced person always explain nicely about the surgical part. I would like to first thank Dr. N.N. Mathur, who explained so nicely regarding the surgical with anatomical correlations. I would also like to thank you, Shivangi, who you explained so much nicely about the anatomy, difficult anatomy, explained very nicely. Then I would like to thank you, Dr. Munin Nanat Borwada, Dr. Kumkum Bara. He also explained nicely regarding every problems.
Thank you. Thank you.
And then I would like to thank you, Dr. Beras, our president, Dr. Anjan, the secretary, and those participating in our discussions, Marcelda and Dr. Kudus Ahmedda, and from Vietnam, Dr. Mukherjee. It is very heartening to see taking participation from Vietnam, taking his time from there. And I would like to thank all other who is present today. And I would like to thank all those PGs, like to take more interest, to take more participation in this, to make it a more success. Thank you all. Thank you for attending this conference.
Before we conclude, I would like to share one thing, that participation certificate has been shared by our webmaster in the chat box. You can download it from there. With this, we conclude our NEBOI classroom for today here. Thank you, everyone. Thank you
Thank
for
you.
your cooperation.
Thank you, everyone.